Hello everyone, please stand by. Your webinar is about to begin. Please use the volume control on your computer, tablet, or phone to adjust the sound for this presentation. Good day and welcome everybody to the Canadian Obesity Network webinar series. Today's presentation is Rethinking Obesity in Children and Adolescents. My name is Dawn Hatanaka. I'm an Education Director for the network, and I have the pleasure of being your host today. This public webinar series is a great platform to help disseminate credible and evidence-based information about obesity. Each month, experts will weigh in on various issues related to living with obesity. If you would like to be part of our community and would want to be first to hear about future webinars, please become a member at obesitynetwork.ca/public and opt in for our newsletter. An archive of this webinar will be posted and available for viewing on the Obesity Network webinars page. Due to the extremely high volume of people joining this presentation, we must disable microphone and question and answer features. However, we do want to answer any questions you might have, so if you have a question that you'd like to ask the speaker, you may do so via social media or in the evaluation survey at the end of this presentation. And now I'd like to introduce our experts, Dr. Geoff Ball and Dr. Katherine Morrison. Dr. Ball is an associate professor at the Department of Pediatrics at the University of Alberta, and he's the director of the Pediatric Center for Weight and Health at the Stollery Children's Hospital in Edmonton, Alberta. Dr. Katherine Morrison is an associate professor in the Department of Pediatrics at McMaster University and is the co-director of the Metabolism and Childhood Obesity Research Program in Hamilton, Ontario. And Katherine, I'll hand it over to you to start.
Sure. Hi, and nice to have everybody join us. Geoff and I are going to begin to talk through a little bit about how our attitudes and our approach to thinking about obesity in children and adolescents has changed. And all of you will be familiar with diagrams such as this one that tell us how complex obesity is, both in terms of understanding its causation and perhaps most important in helping children and adolescents try and address it within their families. However, we've tried to simplify it by thinking about it as a balance of energy, and you've heard lots about food intake and physical activity, but we've really come to understand that there's much more to it than that. We think about the physiology of the individual as well as the environment in which they're living, both from an activity and a food perspective. And I think one of the key take-home messages today is going to also focus on the psychology of the individual as well as the social psychology. And so all of these elements are beginning to shift the way we approach the children that come to us in clinic. So when we think about the prevalence or how common obesity and overweight are in Canadian children, we look at diagrams such as this one, and on the left shows the sort of great increase in obesity back from the late 70s through to the early 2000s. On the right-hand graph, though, in data from Statistics Canada, you see that, in fact, the total overweight and obesity has actually appears to have stabilized in Canada. It's still at a very high rate of almost 1 in 3 children, but appears to have stabilized over the last 5 to 10 years. That's a little bit of good news. The challenge that we're continuing to see, however, is that the prevalence of very severe obesity in the U.S. as well as in the U.K. and in New Zealand, and we fully expect that's also true in Canada, is continuing to increase. And so children with the most extensive obesity are actually becoming more common, and something that we're seeing very commonly in our clinics, as I'll come to you about in a few moments. What you'll note, though, that this is based fully on the weight for height of the child, which we read as body mass index or BMI. We don't think that that's actually truly addressing the health of the individual. This graphic shows the new WHO curves and considers that obesity and overweight in children are based on their percentile. But again, this is just looking at the size of the body as opposed to the health of the individual. And we know that obesity in children, just as in adults, is associated with many other adverse health outcomes. And if you look on the graph, this is sort of on the left-hand side, is the traditional summary of the multiple health problems that children with obesity can present with. The graphic on the right shows a slightly newer approach to thinking about childhood obesity, and I really want to emphasize for you that perhaps the most common issue that we identify in children with obesity coming to our clinics is mental health issues, which can begin or be associated with low self-esteem and certainly progress on to be associated at times with mental health disorders, including depression and anxiety. And children who are in our clinics very often talk about bullying and their experience in the school and their own social environments. And sometimes even, unfortunately, in other aspects of society where adults can be quite judgmental of children with obesity and their families. So we're certainly thinking that this is a much better recognized health outcome of childhood obesity than was true in previous years. This has led a group of clinicians here in Canada to rethink the way that we approach the health in children with obesity and to rethink staging of obesity, if you will, rather than basing it solely upon the body mass index, to also consider the other important health outcomes and health influencers in that child. And this was proposed by Astasia Hagianakis at the Children's Hospital of Eastern Ontario as the lead author on the manuscript, which is referenced on the bottom right of the slide. I'm going to summarize it briefly here, that similar to the adult Edmonton obesity staging system, the EOS-P has 4 stages. Stage 0 would be individuals who have no complications or health-related challenges associated with their obesity, progressing up to stage 3, which would be the most severe form. And I recognize that you can't read all of the small detail on the graphic, but what I wanted to emphasize that was the focus on what would be the 4 M's, and I've just briefly covered those. So the first would be metabolic. So those are disorders such as changes in blood pressure or cholesterol or lipids. There's also the mechanical issues that can be associated with obesity, and these include issues with arthritis and with sleep apnea, for example. So in stage 0, there's no functional limitations relating to mechanical outcomes. The third M is the mental health of the individual, and so the clinician would classify or consider the mental health. This includes conditions like anxiety and depression that I mentioned earlier, but also includes attention deficit hyperactivity disorder and body image preoccupation, as well as other conditions. And so that is scored as well by the clinician. And the final one, which is quite different really from the adult EOS, is the milieu, where we're really examining the environment, the social environment, and the family environment that the child is living within, and it can have no issues whatsoever, but there can be, quite severe interpersonal, intersocial relationship issues within the family. Socioeconomic issues as well are included within this. So our approach really now is to consider a child far beyond what their height and weight are, but to try and take into consideration the entire health history of the child as well as the environment in which they're living as we think about staging the EOSP staging. The way we think we might use this is if the child has a stage 3 for any of the 4 M's, then they would be considered to be a stage 3. Similarly, a child with stage 0 would have a stage 0 for all 4 of the 4 M's. And we think that this may eventually help us to design clinical treatment programs that are geared and directed to the stage of obesity that the child has. One of the research aspects that is taking this one step further is going on with a team of clinicians and scientists across Canada in the CanPower study. And in this registry of approximately 1,600 children across the country, we are utilizing the data that we're collecting to try and stage the 4 M's for each of the children and examining the health of the children utilizing this new approach. So we hope that that's going to assist us in trying to better design and evaluate treatment programs for children across the country. And Geoff, I think I'm going to pass it on to you.
Thanks very much, Katherine, for setting the stage for us. But what I'd like to talk about over the next few slides is some of the challenges that we experience in offering services for boys and girls and families across the country, and some of the key things that we've been doing research on, both Katherine and myself and colleagues from across the country, relate to issues regarding things like initiation and attrition and adherence. So it's been a few years now since we started and actually ended the study. We've been fortunate to publish a few papers over the years related to the topics highlighted here on the slide around initiation, continuation, and termination. So what we did with colleagues from Vancouver, Edmonton, Hamilton, and Montreal was we wanted to learn from families, and we wanted to understand their experiences and their stories and use that information to help guide the services that we offer. And as Katherine's example shows nicely, we use data, objective or quantitative data to drive that, and in this instance we have qualitative data to help drive that as well. So in this study we recruited about 100 families from across the country, and what I wanted to do is talk about one specific study that we did that included 18 parents, and these are boys and girls and families who were referred for care but never showed up. And Katherine will recall when we had these conversations early on that we weren't sure if we were going to be able to recruit anybody because these are families that were referred but then never attended. We were fortunate that we were able to get in touch with about 18 of these families because we wanted to understand their story, and you can see their descriptive characteristics here on the slide. And what I'd like to do is to go through what we learned, and of course things are always more complex than what you originally assume on the surface. And when we talked to families, we learned a lot about what their reasons were, decisions were regarding to not initiate care after being referred. And you can see here we had families that didn't perceive weight to be an issue, they didn't perceive the need for further action, there were barriers that they had to participation, and others just had no initiation or no intention to initiate care. I'll go through these fairly quickly, but the first group is that maybe stereotypical group that we think maybe there are some families that are in denial, and I don't want to use that word because that, in a sense, that underrepresents the complexity and the range of issues that families reported. So there certainly are families that didn't perceive weight to be an issue, or they didn't perceive health to be compromised in boys and girls that were referred. Other families didn't perceive a need for further actions. So families were already engaged in activities or receiving support in other places and already felt that boys and girls had a healthy lifestyle, so they weren't necessarily motivated to engage in health services. Others clearly had no intention to initiate, and for a variety of reasons. The costs that are associated with that, some inability or lack of confidence that they would be able to meet the demands of the program. Others didn't find that the programs that were available locally were suitable, so their perceived efficacy of the programs, the approach, the focus, the delivery wasn't going to meet their needs. And others felt like they wanted some different sorts of support and different sorts of approaches than what were offered locally within that program. Others that are probably more well characterized in terms of barriers to participation, things like distance, lack of time, motivation, and money. Those are fairly well characterized. But there's other issues as well around misperceptions that families had about the program. Sometimes that's from their own experience. Sometimes it's how the program was explained to them by another family or by a healthcare professional. So with that qualitative story really provided some richness for us to have a better, I'd say, conceptualization of issues that families present with, and that's important for us to attend to, and we'll get into that a little bit later on. But complementing that qualitative side, we were fortunate in Alberta to have provincial data, and this is data of boys and girls who were referred for weight management, multidisciplinary weight management, over a 3-year period. And in this sample you can see on the slide here, we started out with there were about 2,000 boys and girls who were referred around the province for care. And I'll let the slide progress and just show you there are some intermediate steps that families had to take to book appointments and then actually attend appointments at an orientation session. Of course, they have to book a clinic appointment, then they have to actually attend a clinic appointment. And you can see there from the numbers that in the end of the day, 38% of all those boys and girls who were referred actually attended the clinic. And what we were particularly interested in is what were the factors that predicted initiation, and it might not be a surprise to people that wait times was one of the factors. So the longer that wait, the longer that time lag between when boys and girls were referred and when that clinic appointment was booked, that predicted whether families would initiate. So the longer it was, the worse off we were at providing that service for families in a timely manner. And also the severity of obesity. What we found from this group, and again, this is the population of all boys and girls in the province who were referred, that as boys and girls got into the severe obesity categories, like Katherine had mentioned earlier, it seemed as though boys and girls with severe obesity were less likely to initiate care than boys and girls who were of lower degrees of overweight and obesity. And one of the things that we talk about often clinically is around goals, and we have goals related to health services and the goal of providing care in the best way possible, making it available and accessible to families. And of course, when families walk through our door, they have their own goals and own definitions of success. So what I'd like to talk a little bit about is that definition of success and the goals. And some of you, maybe a lot of you, are familiar with the most up-to-date clinical practice guidelines we have in Canada. You may not know that, but they're going through the process now to update them for adults. We're still trying to figure out how we can do that for pediatrics as well. But based on the best available evidence back in the day, this is what was recommended, of 5 to 10% weight loss. And this was an adult-oriented goal. In pediatrics, it's a little bit different, and Sarah Barlow and colleagues from the States have this as a guiding document, and you can see here their definition of success, or the goal that families or children should be striving towards is to reduce their BMI less than that 85th percentile. But what we don't know, or we don't know as much in children as we do in adults, is what degree of change in weight status is associated with health improvements. There's a few studies now, and this is a little bit of an older one, but it was a nice example from Germany, where the change in BMI Z-score was linked to healthcare improvements. And you can see here, after the fact, the researchers grouped boys and girls into different categories according to the degree of reduction in their BMI Z-score, which is what we use in general to, or percentiles and Z-scores are generally used in boys and girls to look at changes over time. And again, there's debate around what metric is the right metric. In this instance, this is what they were using. And they showed after a 1-year lifestyle and behavioral intervention, you can see here that in group 1 that gained a bit of weight, insulin resistance got worse. But in group 3 and group 4, where they were achieving reductions in BMI Z-score, you can see there that LDL cholesterol for group 3 and LDL cholesterol, triglycerides, blood pressure, and insulin resistance all improved, suggesting that these may be some cutoffs that we can use clinically and for sure academically to provide some insight into the kinds or the degree of improvements and the types of metabolic improvements boys and girls can achieve with lifestyle change and weight reduction. These are qualitative data from the Watch It program in the UK, and this is a family-based pediatric weight management program, and I provide this as perspective because what I showed previously were objective, quantifiable, traditional sort of metrics that that we rely on to guide some decisions around the degree of improvements. Well, this is a nice complementary perspective to show that when you ask families about what they would like to achieve and what their success indicators of success are, the story is a little bit different. You can see parents here of this sample. There are about 25 to 30 families in this smaller sample, but parents focused on around half wanted their child to lose weight. They wanted to have improved mental health outcomes for their children. Children almost universally said they wanted to lose weight. None of them mentioned self-confidence as a goal, and you can see one of the things that came through with these interviews was boys and girls wanted to be thin, wanted to be skinny, and they wanted to be like their peers and the other kids in their class. So as a clinic here, and I'm sure like Katherine and our colleagues across the country who do this sort of work, we see this all the time where moms and dads may have a certain goal. Children will probably have a different goal in terms of the care that they, or the outcomes that they would like to see from the care that comes through, that they're able to achieve through the program. So this is a couple of years ago. Katherine and I are close colleagues, and we have a lot of good colleagues across the country. It's a very collaborative group that we work with and share a lot of resources and information. And one of the things I did a little while ago was just send a fairly informal email to a bunch of colleagues from across the country, and they circulated those emails to clinicians in practice. And I asked a very simple question. In a sentence or two, how would you define success in weight management for the families that you see? And I'm going to go through a few examples here. This is one of the first ones we got back, and it may be a bit more traditional, maybe a bit more what you might expect. From this program, their primary outcomes were improved quality of life, improved psychosocial and physical morbidities, and stabilized weight trajectories. So in a way, it kind of touches on the EOSP, some of the range of factors, the range of issues that families often present with. Another clinician emailed back to say for that, for her, in this instance, him or her, families who are ready to make changes for better health, move them to be eating more healthfully and more physically active that are sustainable. And I think what a lot of us see clinically is that a lot of families struggle with moving from awareness to readiness to change. And building a relationship there is invaluable between clinicians and families. Other families, if they can remain open to attending their appointments, even if they're not actively working. So this is a nice example of the reality of doing this sort of work, where we may have a very specific goal in mind as a clinician, but if families can just make it through the door and get their, sort their lives out so that they're able to participate, then as clinicians, it's a wonderful goal for us to build that relationship and rapport with families to help them do what they're ready, willing, and able to do. And the last quote I received back is, emotionally healthy individuals and families who acquire knowledge and skills that promote healthy lifestyles and self-management. That was the goal for another clinician. And Katherine, I'll hand it over to you.
Yeah, so thanks very much, Geoff. One of the issues that we've seen in terms of patients not initiating or coming into care is sometimes the way that the referral has been discussed with the family, and understanding that it is sometimes very difficult for clinicians. It's probably the most common question that I get from clinicians when I speak is, how do I actually approach this topic with families and with the children themselves? And as a tool to support families support clinicians, I should say, in actually asking these questions, there's been a tool developed called the 5 A's of Pediatric Obesity Management. And it's really to help us to sort of speak to how do we begin to address this in our relationships with our patients. And it begins with asking permission to talk about weight. It progresses on to assessing the obesity-related risks and potentials for the individual, trying to understand the pathway that they've taken in coming to see you, to advise about health, both benefits and options that there might be to address obesity if it's recognized as something that the child and family want to work on, and then to agree on a realistic plan. And this is, Geoff has spoken about goals, and so developing with the family together a SMART plan and assisting them in achieving what those goals may be. And you'll notice as well what's very important is to note that there's an arrow that goes back to the beginning again. And so in your follow-up, it's very important that you come back to how things went in the goals that had been established or discussed initially, and then reapproaching the management based on their answers to you. So I wanted to update this for everybody. It's an important and very useful tool, I think, for clinicians, and one that is available through the Canadian Obesity Network's website, or these can be purchased to be placed on your desk. So I wanted to highlight that. And Geoff is going to speak to us about one other tool that has been developed to help facilitate communication with families.
Thanks, Katherine. One of the things we hear often is that health professionals who don't necessarily deal with obesity or weight management on a day-to-day basis would really benefit from some tools and resources to help them work more effectively and purposefully with families. So we did some research a few years ago, and we're fortunate to work with the Canadian Obesity Network to design and develop conversation cards. So full disclosure, this is an initiative that I've been involved in from the beginning, and we now have a product. It's been available through the CON website for a few years now. It's been purchased by a number of clinicians practicing across the country in the U.S. And it's meant to be a communication tool. It's meant to provide some practical things to put power in the hands of families and some control to guide the conversation. Weight is a very small part of the issues that came through on these cards, and the cards are populated with statements that we heard from families through a lot of our qualitative research. And we know that there certainly are families who have enjoyed using them, and clinicians like to have something practical and tangible. It certainly isn't rocket science, but it provides a different way to interact with families in a way that is it's designed to hopefully address issues that families can address, want to address, and clinicians can support them with. So with that, Katherine and I just had a couple take-home messages to share. One is the point that she emphasized really well at the beginning, was the way in which we conceptualize obesity goes far beyond BMI. Broader health outcomes are critical, and it's important clinically to focus on those other, and mental health is a nice example of that. The key for us is to not just focus on it, but also to demonstrate and measure, as researchers, measure that these outcomes can improve with respect to the interventions and services we provide. We know that families have a lot of things in their lives, and health is just one aspect of that. And we know that when families are referred, they may or may not accept that referral and may or may not engage in care. And there's a whole bunch of reasons why people do that. And one of the things we're learning is that it's important to keep talking about and keep presenting opportunities for families. If they say no once or decline once, it doesn't mean that should be the end of the conversation. It really should be the beginning. And lastly, we know from some of the quantitative data that there are some reductions in BMI-Z score that are associated with cardiometabolic risk, but as I mentioned, success should be defined in lots of different ways that meet the needs of the people involved. And with that, I think I can speak on behalf of Katherine and say that we want to acknowledge all the funders who've been supportive of our research over the years, and we thought about whether we would have our list of colleagues on here as well. That list would probably be a few slides long. So we're really fortunate to have a lot of support and a lot of wonderful colleagues and trainees who work with us and continue to work with us to help move our research programs along and be able to share this information with you. So with that, thanks very much.
Thank you.
And that concludes our webinar for today. Thanks so much to Drs. Ball and Morrison for sharing this information. If you're a social media user, you can tweet to us using #ObesityTalk, send a message on Facebook, or click the survey box in the window on your screen and complete the survey. You may now disconnect and close your browser window. Have a great day, everyone.